So lots of questions, lots of answers. Dr. Slovin and Dr. Autio, both of you are at a world centre of excellence. How often do you see patients coming in for a second opinion where you think, oh, if only I'd been able to meet with you a year ago, 6 months ago? Do you find that despite all these great advances that people who need them are not getting access as quickly as they should?
I would say for the most part, I think patients are getting appropriate care now.
Is this on? Yeah.
It's not working. I would say that I'm still not working. Can you hear me if I... Wait, no.
Turn it on.
We can all hover around there.
Yeah, hover.
We'll hover.
We'll hover.
So I would say for the most part, I certainly do see patients who are coming as a second opinion. I would say that the majority of the time, patients are receiving appropriate advice. When it comes to clinical trials, that is something that's more nuanced, and their referring oncologist certainly might not be aware of all the clinical trials, but I would say for the most part, when it comes to standard of care options, I wouldn't say that I'm seeing patients being mismanaged in any way. Maybe it's because we live in New York and there's so many great centers around that the knowledge is there.
We do have some academic snobbery, I'll be the first one to tell you, unfortunately. But there's still, there are general oncologists, and the oncologists that are serving communities are usually dealing with multiple solid tumors. So I think Karen and I both, doff our hats to them because they really know a little bit about a lot, and they're able to take care of patients. But every now and then, there's somebody who comes in the retrospectoscope and say, Doc, did I do the right thing 5 years ago? And I always tell people, you are making the decision based on the information that you have at that moment. 5 years down the line is not what you want to do in the retrospectoscope and say, well, I shoulda, coulda, dida. The point is you had the information, you're making your decision on all the information you have right now. That's number one. Number two, I had a patient who came in recently from northern Michigan, not sophisticated with regard to oncologic issues, but came in and during our exam was jumping off the exam table, squatting, moving, and clearly in discomfort. And when I looked at the bone scan, it lit up in the central part of his spine. Didn't surprise me, but what surprised me was the fact that his local doctor, in trying to do the right thing, I guess did not scare the patient sufficiently, such that he was offered a shot, said, no, I don't want to come in and get an injection. I want to come to New York and see what they say. And then she says, well, when you come back, we're going to send you for radiation. But what would have been very helpful, and here again, it's about the nuances. He should have had an MRI because he had 2 gigantic cord compressions and 2 compression fractures, such that I had to immediately admit him. Now, again, I'm very we are very, very subspecialized, so we know nuance, which could be, at a loss in others. And then while he was there, we scanned him, and he had a liver metastasis, and when we biopsied the liver metastasis, it turned out to be metastatic colon cancer, because he'd never had a colonoscopy. So, there's no right answer here. It's a great question, but I would say that for the most part, I would say everybody has been managed appropriately and has done the right thing, and their doctors have done wonderfully. It's just a little of the fine-tuning that sometimes is lost in translation.
This microphone's not on.
Come back.
It's on.
So, 2 questions I have are, if hormone therapy is failing and the PSA is rising, and we've all heard about the side effects of hormones, the short-term side effects of fatigue, low energy, low libido, the cognitive impairment, and of course the long-term side effects of osteoporosis and the cardiac risk factors. Question that patients ask a lot is, well, if these hormone therapies are failing, why do we continue them when patients are on medication for castrate-resistant disease? And second question, we're hearing so much now about immunotherapies, sexy, trendy, the new way to treat cancer. Lots of patients are saying, well, maybe if I delay having my prostate removed by a few years, I won't ever need it removing if you treat me with immunotherapy. Comments on those 2 questions?
You may notice that no one ever has the poor pitiful for women who go through menopause, right? So women have loss of libido, loss of desire, hot flushes, hair is growing in places that you never had hair grow before. So to be perfectly, everybody's very empathetic about men, and I'm very empathetic equally, but I think we don't give women enough credit for trucking through the fact that they're in menopause and they're having drenching hot sweats. And
You're
everything.
doing a great job.
So I guess the issue is, and Karen, I'm sure is going to weigh in on this, in terms of the hormonal therapy, we do know that Lupron or Eligard or Zoladex will maintain control of those cells that are still sensitive to the effects of hormones. So there's never been a randomized clinical trial that has ever really explored whether or not, while you're castrated for X number of years, should we take you off. Some people make the argument that if they've been on hormonal therapy 5 years, 10 years, 20 years, if you take them off, what's the likelihood that their testosterone is going to come back and you're going to get a wiggle in an area that hasn't wiggled in many years? So, but we do this largely by convention, making sure that we are very thoroughly keeping the testosterone at bay.
Yeah. No, I completely agree. I think the bottom line is things will get worse if you come off therapies that are lowering testosterone. It's still a big driver of the disease. It will get those cells that are not yet castration resistant, but if all of a sudden you open up the floodgates with testosterone, yeah.
So just in terms of, there was a trial that was reported at Hopkins, although we did something very similar to it many years ago, which was the intermittent use of testosterone. The idea is to cycle the cells, feed them, then withdraw it and starve them to death. And a lot of patients came in wanting to say, well, I want you to give me testosterone, even though I can't qualify for the clinical trial. And I know Karen did an excellent job of talking about clinical trials, but the enrollment sometimes is very, very restricted. We only want people who we know we can follow reliably and who we know will meet the criteria of safety for their disease. Nevertheless, I have patients, as a physician, the physicians are the worst patients on God's earth. I tell you this right now, because they micromanage, and I micromanage also. But the point is that the upshot is that they want something that is not right for them. And I'm very blunt with my patients. I'm not, what's the word? I would say that I'm very honest and tell patients, as is Karen, that if we disagree with the treatment, it's too bad. I disagree because I have reasons to disagree. That being said, patients will go on the internet and they'll go to Joe Blow's clinic out in Cleveland or Oshkosh or wherever they want to go, and they will get the treatment that they want. And then a year later, they'll come back on my doorstep and say, well, Dr. Slovin, my PSA is rising. I never told you to go there. So, this is not about me investing in your enrollment on a clinical trial that I have or anything that I'm doing for me. This is about what I think is better for you, as if you were my father, brother, uncle, and father-in-law, all of whom have had prostate cancer and unfortunately died of prostate cancer. Nevertheless, everybody has a story. So nevertheless, in this particular case, this patient who has high-grade disease, has been with me from diagnosis onward, decided to have his urologist give him the testosterone, which he cheerfully did, in spite of my saying I will not do it. And lo and behold, suffered a major cord compression that required emergent decompression laminectomy in the operating room. So, you can't be a wise ass. If one doctor says, do this, the urologist then says, well, we'll do it for you, see how it works out. You got to do risk benefits. In terms to the very good question about immunotherapy, I personally am not a believer of holding back treatment. Remember, even if your PSA is stable and you're newly diagnosed, that cancer is not sitting there and twiddling with you because you have to go on your cruise or you're going away for whatever, because that's what I hear. Well, we already made plans. Okay, so then it's already been 5 months since you were diagnosed. You want to go another 4 months. The cancer is growing, and to wait to give immunotherapy at that juncture is not my idea of a very well-informed decision.
Can we just say a few things about the absolute craziness of people in the United States having to fly to Heidelberg or Australia to get scans where there's good evidence medically that these scans are so much better than the Mickey Mouse technetium bone scan, that we've been using forever, and yet these new scans, the PMSA scans, the sodium fluoride, the choline PET, why is this going on?
Because there's a marketplace and there's some misplaced information. I think Karen and I both have had crazy, forgive me for saying this, I say this with love, but crazy patients. And I'm thinking right now of the fact, it has nothing to do with trust or mistrust of the doctor. There are some patients who feel that they are in jeopardy. There's never a patient who's at the cusp of death. I'm doing this 26 years and no one is, hanging on like that. It doesn't exist that way, but in their heads they are, and that's where we have most of the problems. I am citing for you now a patient who saw me many, many, many years ago, maybe 10, 12 years ago, and lives in Albany. He's a dermatologist. He's 82 with a much younger wife by 30 years. I won't comment on that, but so, he's very robust. I give him credit. Very robust, and he'd had primary radiation therapy and came to see me because he was recently diagnosed with lung metastases. He was having some really bad shortness of breath, and he got it into his head that this is probably his prostate cancer. I met him on day one. I hadn't seen him in years, and his PSA was 0. Now, of course, Gumbas, Ditzels, Gumbets, that's my own staging system of little, big, and intermediate things in the lungs were biopsied, came back as PSMA positive prostate cancer. So standard of care, as you all know, injection, hormones. So we gave him a hormone. It came back close to 8 weeks later. Testosterone was where it should be, all the way down, and the PSA was less than 0.05, the lung lesions didn't change. So remember, he's going in with a PSA of 0, but the lung lesions are there. We added abiraterone. Another 2 months, nothing happened. And then we gave him chemotherapy, 2-drug couplet, and it didn't change. And then and he was fine. And in his head, he's looking at the scans and says, well, I can't breathe. I said, your oxygenation is 99%. You can breathe. It's not really hurting you. I reviewed the scans with multiple radiologists, and everybody said, well, there's plenty of lung to breathe. So the patient said, I'm going to Heidelberg, which was a headache unto itself. So he gets this injection, as Dr. Autio alluded to, and then he had a second one. Then he comes back to see me for the third one. In between, I'm getting emails that I did not invite. And he keeps saying, Dr. Slovin, I have to tell you, there's minimal change. My PSA is still 0, but the scans have not changed as yet. And I really want to talk to one of your other colleagues who does this more. So my other colleague was very gracious and talked to him on the phone for 30 minutes and told him the same thing that I did, which is wait and see how it goes. In the meantime, the patient's sending me faxes with a litany of complaints. You have no idea, I'm sitting in a bare German room and the food is horrible and I have to travel 9 hours to get there and I've left my wife home. What am I supposed to do with that? I can only do what I do. Was it a reasonable approach? Yes, for him. But there are patients who don't have the financial wherewithal to do that, and there's no guarantee that it's going to work. So we're a work in progress right now because, quite frankly, we have, he's going for his third scan, and I already dread this because if he does not see the response that he wants, this is going to take a psychological toll. And very often, we as doctors don't really give a damn about the PSA. Dr. Autio and I come from an institution that has established guidelines within our group that really, if scans remain stable, that's great. Forget the PSA. If PSA can be going up slowly, but if your scans haven't changed in 2 years, 3 years, 4 years, that's okay. You don't have to live your life by a number. Remember, in the 1980s, we didn't even have a PSA till roughly 1989. We lived from scan to scan. And PSA has done nothing but aggravate people, change people's quality of lives, and add to the anxiety of both the doctor and the patient.
Susan, what really upsets me, though, is that when patients come in who've had surgery and they've got a rising PSA, I chair the multidisciplinary prostate cancer clinic with medical oncologists Bobby Liao and Dr. Richard Stock. And it's so upsetting that patients are going through enough distress, worrying about whether their cancers come back, and then we're trying to get an Axiom PET covered by insurance, and there's all this back and forth, back and forth. We're all busy. We haven't got time to spend an hour on the phone per patient trying to convince an insurance company to pay for an Axiom PET, which is really going to help determine whether that patient needs, adjuvant radiation, salvage radiation therapy. I mean, it just seems so wrong that patients should be worrying about whether scans get approved.
We've been very fortunate about having our own patient financial services that actually will come down and be the champions for the patients. I thought it was very interesting recently that I think Karen and I both have clinic twice a week, and they're rather robust clinics. And the patient looked at me and said, what do you do the rest of the week? You only work 2 days. And you really have no idea, because it was just on the cusp of my trying to get an approval for a bone scan. Now, how hard could that possibly be? And I talked to, in case you didn't know, a lot of times the doctor who is part of the insurance approval process is a generalist, or it may be a nurse. And so after I gave my spiel, the guy had a high-risk prostate cancer, Gleason 9, failing therapy. I needed to see where we are as a result of treatment. He says, well, ma'am, I love being called ma'am. I have to deny you, but I will have you escalate to an oncologist. So my feeling was, well, if it's a medical oncologist, I'm prostate queen, I can take you down. You're princess, I'm queen. But my feeling,
Let's
and you can be
that
junior
later.
queen. I said I can take down anybody in justification. That person would not budge. And the woman says, but our guidelines. I said, screw your guidelines. I really did say that. I said, you have to understand, these are established NCCN guidelines, not your insurance. Well, she says, I'm sorry, doctor, I have to follow. I said, but you're an oncologist. She says, I understand. And it's a young man, he's 50-something. I said, this is ridiculous. And we were turned down. So, I hate them.
So could we just clarify a few points about genetic testing? There's been quite a few questions about that.
Yes.
Patients are confused about, we know that prostate cancer tends to run in families. And when we start talking about genetic testing, I don't think we're very good at explaining the difference between the genetics of the tumour versus the inherited risk that you may pass on to your sons or brothers if it's a family. Can we just address that issue?
Absolutely.
And the difference?
So it's a very important distinction. And essentially there are ways of testing to see whether or not somebody's cancer, if the tumor itself has created certain mutations. Someone's prostate cancer could have a BRCA or a BRCA mutation. That doesn't mean it's necessarily hereditary in nature. There are separate tests that will identify whether or not a mutation that's found in a tumor is also hereditary. And that's when I referred to, with some platforms at least, you're giving a separate tube of blood or a saliva sample, because those are your normal cells. If you can find a BRCA mutation in a normal cell, you know that's something that was hereditary in nature. And these have to be done sort of separately. The platform that we use at Memorial sort of automatically tests for that distinction, provided that patients want to know if we find a mutation, if it's hereditary or not. But I will mention that there are some commercially available platform studies that are widely used that do not distinguish between hereditary mutations and mutations that are just in a tumor. However, an astute oncologist, urologist, physician, if they see that this tumor has a certain mutation like BRCA, should be sending their patient to see a genetic counselor or performing additional testing to figure out whether or not that mutation is hereditary in nature.
And surely that accounts for a lot of the discrepancy in care across the country. I mean, lots of patients are not even having any discussion whatsoever about genetic testing. How do we get the word out to make sure that the right patients are getting the right evaluation, and how much do you think that affects care?
Yeah. So I would say, first of all, for men with metastatic prostate cancer where you can identify it on a scan, all men in those scenarios should be covered to have genetic testing of the tumor performed, or in addition to hereditary testing. When it comes to men that have localized prostate cancer that is potentially curable with surgery or radiation, at this time, insurance companies are, generally speaking, are not approving of testing of the tumor itself. However, for men that meet certain criteria with family histories, they are eligible to receive testing for just the hereditary genetic mutation. So insurance coverage certainly does play a role. And I would say for metastatic disease, absolutely standard of care. For non-metastatic prostate cancer, there are some nuances to when you can order these tests and have them covered by
And you've
insurance.
also talked about the BRCA gene, that's the breast cancer gene. Men often assume that they inherit the genes from the father because it's a male cancer, but we know there is a link between breast cancer and prostate cancer, so you can inherit faulty genes down the maternal pathway as well.
Yeah, absolutely. And then I'll also just say that if somebody has a very strong family history of prostate cancer, father with prostate cancer, uncle with prostate cancer, if you have these genetic tests done and it doesn't reveal a known hereditary mutation, that doesn't mean that your children don't need to undergo prostate cancer screening, or your sons, because there are inevitably genes we don't know about and have not discovered yet. So while it can be reassuring if somebody is tested and doesn't carry one of these DNA damage repair alterations or mutations, I would say when it comes to family members and sons in particular, that certainly doesn't mean that they shouldn't undergo routine screening.
I just want to add one thing. It's really important as your disease transitions over time and you have different sites of metastases, and as your cancer progresses despite every treatment you are having, it's really advised to get biopsy of lesions to see how your cancer has changed. Has it acquired a mutation that may make you very susceptible to some of the drug classes that Karen had alluded to earlier?
We know that prostate cancer is more common if you have a family history. We know that 1 in 6 men get prostate cancer. 1 in 3 men will get prostate cancer if they have a first-degree relative, higher if it's more than one. Black men, we know, are at increased risk as well, and often are not as fully evaluated and as quickly evaluated as they should be for many, many reasons. 25 years ago plus, when I was at medical school, we were taught that black men get prostate cancer earlier, they get more aggressive disease, they're more likely to die from the disease, they're more likely to have a recurrence. Is the biology of prostate cancer different in different races, do you think?
I would say there probably is a different, I want to say a different etiology, but the point is epigenetics. So it's the exposure to your environment in addition to your own genetics. Is it the food? Is it the polycarbons we're inhaling? Is it something that you've done or been exposed to that is a predilection? It's interesting because a number of years ago, and Dr. Cheetham probably would remember, there have been several papers that came out trying to justify why men of color had a much higher rate of very aggressive prostate cancers. And don't laugh, but they looked at a few studies, and among them were the number of times you had hanky-panky in the course of a week. And if you don't know what I'm talking about the word sex. So the idea was if you had intercourse more than X number of times a week, did that mean that the African-American man was higher than the Caucasian? And the answer was no. Then the other question came was how many children you sired. So if you sired more than 6 or less than 6, did that make it? So this is what we're talking about in epigenetics. But there definitely is a very different background that is probably governing the more aggressive nature of the cancer in men of color than Caucasians.
And some data that the androgen receptor may be resistant to some treatments. And then you've both touched on clinical trials about options that are available to patients, and it's fantastic to hear that